well that that's taken me a couple of minutes, or rather it doesn't bode well when I'm going to be talking to you about how to do things, and I'm thinking it's taken me about 2 minutes just to show how to display my screen, so I do apologise for that. So yes, my name's Michelle Briggs. I'm the Clinical Professor of Nursing. That's a joint post, so I have 50% of my time is at the university, where I lead a research group, and the other 50% of my time I am, like Alice and Sophie, a jobbing clinician, and my job within Manchester NHS Foundation Trust is as Assistant Chief Nurse. Primarily my portfolio is research and the development of clinical academic careers. I'm also the lead for capacity building in ARC-GM. And what I've been asked to do today is be able to, I'm trying to get the next slide, but it doesn't seem to want to go. Next. I'm going to talk about three things. One, why invest in research? Two, I think it's interesting, we've used the word research an awful lot, but I want to really unpack what counts as research, and then also how we realise the benefits, both in an academic setting and also an NHS setting. So this slide I'm showing you is a slide that we use in our standard slide deck for all our ward managers. Our research champions will use this at ward manager meetings to talk about research and some sort of myth busting. So you've heard a lot of people talking about research being everybody's business, and the corollary of that is the myth is that the reason that we need to say that research is everybody's business is that often people say research isn't part of our job. So the things that we unpack of what people mean by that is, I don't know what research is, so we have research champions with contact, visible research champions in ward areas and on in NHS bases to explain what research is, but more importantly, to explain how you can get involved. Also, people say, well, I don't have time for research, and so we start to break that down into, well, you can do a small part of research or be involved in a small thing, which takes less time, because literally none of us have time for things that we don't think are a priority. So we need to be thinking about this as a priority. People say, oh, I prefer working with patients. I don't know any of my researchers who, or people that I'm working in research teams with who don't work with patients. So actually that's a myth, that research involves working not with patients, that research doesn't help my patients. And I'm going to talk a little bit on the next slide of, I think research does help your patients. And then research is only done by professors, and we talk about research is actually a team sport done by all members of the NHS community. And this is the slide that I wanted to focus on in terms of, and other presenters have touched on this, is why should we do research, or why is it so important? And you've heard there's some references at the bottom here of the evidence for this, but organisations that engage in clinical research have better outcomes. And when we mean better outcomes, that's in mortality and morbidity, and that's beyond, that's a better patient outcome, irrespective of whether you're in the research. But also, and the things that I would be saying is that as an NHS or a social care organisation, you can't afford not to be involved, is research activity has been associated with reduced staff turnover, and staff are more likely to recommend your place of work. So, and there's evidence to suggest that's the case. And this is a direct quote from a line manager whose member of staff was involved in an internship, and it said, I hadn't appreciated the positive impact that it was going to have on the wider department, and certainly something that has now rippled through the rest of the department. In terms of, you've heard mention about CQC appraisals, well, there's direct evidence. This study that I'm quoting here is from 129 CQC appraisals of NHS England trusts, and it showed that there was a significantly associated with increased clinical research activity drove better information provision for inpatients, particularly about medicines management. That's a real safety risk, and it's certainly a driver that we should be interested in. But equally importantly, it contributed to a better inpatient experience overall. And finally, in terms of the metrics, increased NIHR adopted clinical trial activity was clearly associated with reduced mortality. And the point I want to make in that box is that link between clinical trials activity and quality was not trust size dependent. So it doesn't matter how big your trust is, there is an opportunity for you to be partnering and participating in research, and it will make a difference to how many patients survive, and the data is clearly there. So I want to focus now on what the second bit of that slide about, well, what do we mean when we say research? It's really easy for people to be thinking, certainly clinicians, to be thinking, oh, well, you know, I don't do research because I'm not leading research, or I don't have a huge grant, or I'm not part of a research centre. But this is a study that I did with colleagues across the UK who are clinical professors like myself. Having said that, it's a rare post. Only 0.1% of the nursing, midwifery and allied health professional workforce is a clinical academic, compared to about 4.7% of our medical colleagues. So still a small percentage within our medical colleagues, but certainly tiny within the other health professions. But what we looked at here was a framework analysis of what made a difference to the success of clinical academics and clinicians being involved in research. And we came up with a framework that shows that actually what we need are 4 different types of research activity. At the bottom here, you can see the spearheaders, and they're people who are leading research activity in their organisations, the university professors, and having those roles embedded, such as my own, where I'm part of the corporate leadership team within, so I'm at executive level making decisions within the NHS. That makes a key difference, but it only makes a difference if I've got, which I do have, my boss, the chief nurse, understands the clinical academic environment and very much supports it. But then what that enables us to do is be able to think about the 3 other groups of clinicians who may dip their toe into research, and that's their research activity. And what I mean by that is they understand what trials are going on in their area, they understand the youth, they know the researchers, and they're being able to, as Sophie says, know who the researchers are, know who to go to, know how to join up. So they don't want to be a researcher themselves, but they've got good relationships with researchers. Only then can people think, actually, this might be something that I could do, and I want to wade into a clinical academic career. And what I mean by waders are those people who have access to and opportunities for masters, MRes and PhD study. And certainly the earlier in the career that you're able to do that, the better. And then after PhD, we need a whole series, and we've called them trackers, because actually you need a really good sense of tracking your way through a postdoctoral career at the moment, because it isn't a clear journey. So, and in an NHS or an NHS organisation, we would argue that everybody should be dipping their toe in research. Some people should move forward to being waders. We need a strong cohort, definitely at least 1 to 2% of our population being trackers, and then they need to be supported by fully embedded spearheaders within their organisation. And why? Why should we do that? Well, what we also need to be thinking about is making, in terms of our sustainable research workforces, valuing all of the impacts of being involved in research. So this is a study by Lisa Newington and colleagues in Imperial, where they asked, it's a qualitative study where managers and research clinical academics were interviewed about impacts and about their activity. It's about 2 groups of interviewees, I think 12 nurses and 10 managers. And the interesting thing that I think that this graphic shows is that we tend to think of direct research outputs, publications, conference presentations, implementation of research, but actually what clinical academics are able to do is all of the other indirect research outputs that we're not good yet at capturing, but we need to be thinking about, and certainly our clinical managers were recognizing, which were guideline development, peer reviewing, shared learning with a team. But the one that I wanted to highlight is recruitment, retention, and staff involvement in research. Because certainly in terms of how we've realized our benefits, this is our current strategy 2018 to 2022 in MFT, where our strategy was that we needed to expose all of our staff to be able to see research visibly happening in the areas that they were in. We deliberately chose expose as opposed to research awareness, because you can be aware of something but avoid it completely. And actually that's sometimes what was happening in research. So we need to, on a basis, ward level, people get exposed to research activity, which allows, and by that I mean making research visible so that people can easily engage. And when they engage, they can see how they need the education and skills to develop embedded roles. And now we're at the stage in 2021 of this strategy that we have a significant number of embedded roles within the organisation, that we can build on that and watch this space for our next strategy in 2022. And so that leaves the final thing that I wanted to say was that we could not do this without our training and capacity building team as well, and our support. We are a very close collaborator in MFT with ArcGM and the capacity and building team. And as Penny mentioned, our research internships, I wanted to leave you with the last quote. I'm going to leave you with next slide, if I can get into our internships. Yeah, so our internships, this is a quote from one of our internships from last year, is that I enjoyed each step of my research path. And Anna would be the first person to say that before she started the internship, she was considering leaving nursing completely. So not just leaving the trust, but leaving nursing. And a 30-day research internship turned that round completely, to the point that she's now one of our research matrons. And I'm just going to leave you with that thought, that actually, how do we invest in research? What I would be saying is we can't afford not to. And I'm going to leave it there.
That's a great way to finish it, Michelle. Thank you very much. That's a really thought-provoking and important presentation.